Good afternoon, everyone. Hope you're all well. Today, in this 30 minutes of time interval, I'm going to briefly discuss about adrenal insufficiency and corticosteroid treatment. Please forgive me if I'm not able to cover all aspects as it is a vast topic. Myself, I'm Shovhit. I'm one of the IT USSO. So let's begin with our slides here. Adrenal gland. The normal adrenal glands weigh about 6 to 11 grams each. They are located just above kidneys. Here is a cross section of adrenal gland. It is made of adrenal medulla and adrenal cortex. The adrenal cortex has three parts. The glomerulus, it produces aldosterone via angiotensin regulator RAS system axis. We'll discuss it on the next slides. The fasciculata, it produces glucocorticoids, mainly cortisol. The reticularis produces androgens like DHEA. The androgens have minimal role in stress. In males, it easily helps in prostate growth, hair growth, and masculine characteristics. In female, it helps in libido. So we won't be discussing much about those medications, these hormones. There are some, we can get this over the counter. It's unlicensed. Sometimes people do use it as supplements. The adrenal medulla produces catecholamines such as adrenaline and noradrenaline. Unlike adrenal cortex, the adrenal medulla is stimulated by nerves. The brain sends signal down the spinal cord targeting adrenal medulla to secrete adrenaline and noradrenaline. Essentially will trigger a flight or fight response, triggering sympathetic activities. This is what we see in acute stress when we are in nervous or when you are running away in fear. The adrenal cortex is responsible for long-term stress response, and we'll go into more detail on this topic. The outer layer is zona glomerulosa. So it all starts with the hypothalamus in the brain. The adrenal cortical secretion also exhibits distinct circadian rhythm with peak levels in the morning and low levels in the evening. When there is a trigger, severe pain or any kind of stressor, it causes the hypothalamus to release CRH to the pituitary, a small gland at the base of the brain, which then stimulates the ACTH into the bloodstream. The adrenal glands are constantly in touch with each other, deciding whether or not the body needs more hormones or fewer hormones. This is called negative feedback loop. So excess cortisol gives a negative feedback. It decreases the production of CRH and ACTH on the circulation, hence by decreasing the cortical secretion. The cortisol has many roles in our body. It usually causes hyperglycemia, high gluconeogenesis, and high glycogen synthesis. It also has properties such as high protein catabolism, high fat deposits in the body. It is also immunosuppressive. It decreases pain sensations, and but it has side effects like it increases chance of infection in our body. Let's say cortisol is like a protective hormone. It protects alcoholic or diabetic patients from hypoglycemia. So this is the hypothalamic pituitary adrenal axis, which is very important for this topic, and it helps in diagnostic purposes and treatment purposes as well. So let's go to another axis, the renin angiotensin aldosterone system. So basically, it all starts with the liver when there is hypoperfusion and when there is concentration changes in our blood. It produces renin, which is then it produces angiotensinogen, which is then converted into angiotensin 1 by the renin produced from the kidney when there is decreased renal pressure. The angiotensin 1 is converted into angiotensin 2 by ACE angiotensin converting enzyme. The angiotensin 2 is a very potent vasoconstrictor. It converts it activates AT1 receptor on the adrenal by which aldosterone is released. Aldosterone enhances sodium retention and potassium excretion in our body, and it increases arterial perfusion pressure, which in turn regulates renin release. So this is a very important axis in our body that it's very important for this topic as well. Because the mineralocorticoid synthesis is primarily under the control of RA system, that is the mineralocorticoid aldosterone. The SPA axis has minimal role or does not significantly impact the capacity of adrenal to synthesize aldosterone. There is a clinical trait of hyponatremia, hypovolemia, hypoglycemia, and hyperkalemia that we can find with decrease in aldosterone in our body. Now, what is adrenal insufficiency? The inability of adrenal glands to generate enough glucocorticoids and mineralocorticoids for the body's needs is called adrenal insufficiency. Glucocorticoids such as cortisol and mineralocorticoids such as aldosterone are the two main group of steroid hormones produced by the adrenal cortex. Like I said in the earlier slides, that the production is regulated by SPA axis or renin, angiotensin, aldosterone system, respectively. Primary adrenal insufficiency. So let's go to the types of adrenal insufficiency. When there is deficiency of aldosterone or cortisol production due to the loss of adrenal gland function, it is called primary adrenal insufficiency. So the trait of hypertension, hyponatremia, hyperkalemia, metabolic acidosis, and we also see skin hyperpigmentation due to increased melanocyte stimulating hormone, byproduct of ACTH, in this kind of insufficiency. It is further divided into acute, sudden onset, likely sometimes due to massive hemorrhage, or chronic, we call it Crohn's, Addison's disease, Addison's disease. So decrease in mineralocorticoid or glucocorticoid primary due to primary adrenal insufficiency. We also term it as Addison's disease. Due to the most common cause of this condition in the western part of the world are autoimmune, more than 70%, I believe, and TB is the most common cause of this condition, addition in the developing world. Some drugs can also cause adrenal insufficiency, with the systemic use of glucocorticoids being the most common cause due to suppression of SPA axis. If glucocorticoids are stopped or decreased too quickly after prolonged use, endogenous glucocorticoid production may not be sufficient to meet the body's need. Some patients on glucocorticoid therapy, it could be via oral or inhalation, topical or intranasal, are at particular risk of developing adrenal insufficiency. This may particularly happen during times of increased need, as patients are unable to mount a stress response by increasing endogenous glucocorticoid production. So what are the symptoms of adrenal insufficiency? The symptoms can be mild, non-specific, may include weakness, fatigue, GI upset, anorexia, weight loss. There could be sugar or salt cravings as well, and orthostatic hypotension, dizziness, or syncope. Many critically ill patients have recently been shown to exhibit low plasma cortisol levels and an impaired response to ACTH stimulation, which is linked to a decrease in survival. The importance of the cortisol response to stress is illustrated by the profound circulatory collapse that occurs in patients with this kind of insufficiency. In ITU, patients with relative adrenal insufficiency may present with vasopressor dependency, acute multiple organ dysfunction, hypothermia, and basically inability to win from the ventilation. Adrenal crisis. So the acute adrenal insufficiency is a medical emergency presents with life-threatening symptoms such as various combination of dehydration, hypotension, hypovolemic shock, altered consciousness, seizure, stroke, or cardiac arrest may develop if left untreated, may lead to death or permanent disability. These patients usually have very, very low cortisol levels, less than 3. Lab findings of insufficiencies are hyponatremia, which is most common in primary and secondary, low levels of chloride and bicarbonate, and high levels of potassium occur frequently. Also seen are moderate eosinophilia, lymphocytosis, hypercalcemia, and hypoglycemia. It also can cause normochromic anemia and prerenal failures. The investigations for insufficiency involves measurement of serum electrolytes, morning or random serum cortisol, and ACTH. The ACTH stimulation tests we usually evaluate cortisol levels in the blood before and after injecting a particular dose of synthetic ACTH. Synacin is a man-made copy of ACTH. In primary adrenal insufficiency, we have low cortisol and high ACTH, whereas in second degree or third degree adrenal insufficiency, we have low cortisol and low ACTH. We have to remember the axis again, the SP axis. Antibodies associated with addiction disease, sometimes we also go for scans, CT scans of the tummy, or MRI of the brain if secondary adrenal insufficiency is suspected. In non-ICU patients, we measure the cortisol level before and 30 to 60 minutes after injection of ACTH. If patients are not critically ill or normal response generates a post-stimulation cortisol level of more than 20, a random cortisol level of more than 20 may rule out the diagnosis of adrenal insufficiency. Random cortisol less than 3 confirms the diagnosis of adrenal insufficiency. In ICU patients, it's a little bit tricky. The use of provocative adrenal stimulation tests in critically ill patients remains controversial. Perhaps the most widely used protocol identifies patients with septic shock as having relative adrenal insufficiency if their baseline cortisol is less than 35 and they respond to an ACTH stimulation test with a bump in cortisol of less than 10, despite having this critical illness. So this is how we diagnose the adrenal insufficiency. Let's go to the management now. Basically, we treat the cause. In management, we go with glucocorticoid and mineralocorticoid replacement. Adrenal insufficiency is treated with physiological glucocorticoid replacement, mainly hydrocortisone, which is most similar to cortisol, prednisolone, and rarely dexamethasone. Patients with primary adrenal insufficiency usually also require mineralocorticoid replacement with fluorocortisone due to aldosterone deficiency. Adrenal crisis is a medical emergency. All patients who are considered to be at risk of or suspected of having adrenal crisis should be treated immediately. Investigations can be initiated once the patient is clinically stable. Short-term administration of high dose of glucocorticoids is never harmful, but failure to treat adrenal crisis can result in disaster. To prevent adrenal crisis in all the situations, we usually inject hydrocortisone. For patients usually on fluorocortisone, high dose of hydrocortisone has sufficient mineralocorticoid effect to cover this. We go by 100 milligrams IV IM followed by rehydration, and we also go with maintenance doses, a dose of 200 milligrams for 24 hours, IM IV, or depending on the patient's response. We'll further talk about this on the next slides. Please do not hesitate to give high doses of hydrocortisone to a pregnant woman. Hydrocortisone is inactivated in the placenta and does not affect the unborn baby. Failure to treat an pregnant woman with adrenal insufficiency can result in disaster. Children can also be given hydrocortisone IV or IM for adrenal insufficiency. Infants less than 1 year go with 25 milligrams, 50 milligrams up to 5 years, and 100 milligrams over 6 years. These doses can be repeated 3 or 4 times in 24 hours, depending upon the patient's conditions and response. So this is basically I've copied this from the trust guidelines. So there's a basically there's let's say there's a trust protocol regarding treatment plans of adrenal crisis insufficiency. On regular wards or ICU, irrespective of whether breathing unaided or supported by CPAP or mechanically ventilated, we inject hydrocortisone 100 milligrams per IV, followed by continuous IV infusion of 200 milligrams over 24 hours. We pause fluorocortisone because hydrocortisone will when we give hydrocortisone, we might not need to replace fluorocortisone. We also need to give IV fluids, sodium chloride, and regularly check urea and electrolytes. For patients with dexamethasone, there are some guidelines regarding this as well. Basically, we continue the same treatment plans. There's not much change. On the recovery, we do gradual tapering of stress dose hydrocortisone down to double regular replacement at the time of discharge. And we restart usual fluorocortisone dose in adults when total daily hydrocortisone dose is less than 50 milligrams. So this is for the adults at hospital. Steroid replacement in severe sepsis and septic shock. We also initiate pharmacological glucocorticoid therapy when there is non-resolving acute acute respiratory distress syndrome. For critical ill patients whose cortisol level is less than 15, we also consider the corticosteroid treatment. For patients whose cortisol level are between 15 to 34, it depends on how the clinical response are, how this corticotropin tests are. If it's more than 9, then the corticosteroid therapy is unlikely to be that helpful for those patients. All patients with adrenal insufficiency and patients considered to be at risk of adrenal insufficiency should be educated on the importance of stress glucocorticoid doses. That is the increased doses for the prevention of adrenal crisis during times of stress, in order to maintain cortisol levels as close to the physiological concentration as possible. Patients with adrenal insufficiency who do not usually require maintenance glucocorticoids should still be advised of the likely need for glucocorticoid replacement during times of stress. In patients with adrenal insufficiency and intercurrent illness, sick day rules should be followed. Basically, we're trying to increase the doses of the steroids. We'll discuss this on the next slide as well. For patients who are unwell with moderate intercurrent illness, fever, or having infections, the patient daily glucocorticoid dose generally should be doubled. For severe intercurrent illness, like persistent vomiting, intramuscular or intravenous hydrocortisone should be given. Patients with adrenal insufficiency are at high risk of glucocorticoid deficiency if they are vomiting or having diarrhea. Patients with established adrenal insufficiency and their family carers should be provided with hydrocortisone emergency kit. We'll discuss this on the next slide as well. To be trained in the administration of intramuscular hydrocortisone and advised to go to hospital if vomiting or diarrhea illness persists. So we really need to be very careful on this kind of scenarios. At home, so there is a guideline for COVID-19 as well. We can escape from COVID-19 in this age. So for simple fever, a new continuous dry cough or sore throat, loss of a sense of smell or taste, aches or pain. People who are adrenal insufficient on maintenance hydrocortisone should take 20 milligrams of hydrocortisone orally every 6 hours. We increase the doses of prednisolone as well, and patients on oral prednisolone more than 50 milligrams should continue to take their usual dose, but split into 2 equal doses, at least 10 milligrams each. If the patient is on pseudocortisone, we continue the same usual dose. If the patient's onset of has symptoms such as dizziness, increased shaking, uncontrollably, like more severe symptoms like confusion, lethargy, vomiting, severe diarrhea, there is a steroid emergency pack that are usually given to the patients. We have to teach them to inject 100 milligrams hydrocortisone in adults, and they'll ask if the patient cannot be taken or kept in the hospital, they should take 50 milligrams oral hydrocortisone every 6 hours at home. So it's a medical emergency sometimes if the patient deteriorates. So we must be very careful on these scenarios. We'll further discuss this on the next slide. So let us go to sick day rule. So patient who are having simple illness, viral illness. So if they are taking a normal prednisolone dose of 3 to 10 milligrams, if unwell with fever, we give 5 milligrams twice daily. If suspected COVID, we give 10 milligrams twice daily. So similar is for hydrocortisone. So we increase the doses up to 20 milligrams immediately, then 10 milligrams every 6 hourly. So double existing oral doses of steroid for up to 1 week is recommended as per trust guidelines. Steroid emergency card. A patient head steroid emergency card has been developed for patients with adrenal insufficiency and steroid dependency who are at risk of adrenal crisis. It aims to support healthcare staff with early recognition of patient at risk of adrenal crisis and emergency treatment of adrenal crisis. All patients eligible should be issued a steroid emergency card. So this is one of the sample of steroid emergency card. It's basically like a credit card. It can fit in wallet. So there are details of the patients, and then the treatment plans on the second part as well. So on the emergency treatment of adrenal crisis, it says immediate 100 milligrams hydrocortisone followed by infusion up to 200 milligrams over 24 hours on rapid rehydration, and we need to discuss with the endocrinology team as well what this is for the children's. There's a steroid emergency card for children as well, pediatric. So there are a lot of informations on this emergency steroid card. So it says the same thing, like if it's less than 1 year, we go with 25 milligrams. If 1 to 5, we go with 50 milligrams. If it's more than 6 years, we go with 100 milligrams. And it helps to treat the condition in time, and it helps for everyone at hospital. So this is the back of the pediatric steroid card. So the current regular treatment for adrenal insufficiency are also listed on the back. So the patients with adrenal insufficiency always need to carry a steroid emergency kit, emergency card, or wristband on the hand. So it helps with it helps in a lot of things. So thank you so much for everyone for listening to me.
Hi everyone. I'm sorry, Shovhit, I couldn't join you for the lecture. But does anyone have any doubts, any suggestions? Feel free to ask now. If there's no doubt, shall we go ahead with the next presentation by Zahra? Zahra,
Hi,
is it
ma'am.
okay if you can start sharing your screen?
Yeah, sure.
And meanwhile, I was watching through the references, so I will advise this to everyone when you're doing your presentation. Whatever the reference that you use, try to write in a scientific manner so that in future when you're going to write paper, it will be helpful for you and it will also be kind of practice. Like for example, there are two patents that I'm aware. One is by ICMJE. I forgot the name, complete full form of this website, but it is one of the PubMed and Cochrane accredited reference writing system. Second one is Vancouver system, and of late Vancouver has updated, I think in the year 2018 or 2019. So please go through the Vancouver reference writing website uh, as well. There is one third reference writing system. I forgot the name, but it is approved exclusively by Cochrane. So please do follow these guidelines of how to write a reference. And in your next subsequent presentations, please do try to write in that manner. It will be helpful for you in future. Yeah. Zara, over to you. I'll keep my mic mute.
Before I start, can I just check if you can see the slides that I've shared? Can anyone hear me? Hello?
Yes, yes, we can hear you, Zara. Thank you.
Can you see the slides?
Yes, yes. Yeah.
Okay, great. Hi, everyone. My name's Zara. I'm one of the critical care pharmacists at Northwick Park, and we're going to be going through a presentation about sedation, but it's going to cover a little bit wider than that, looking at analgesia and delirium as well.
Zahra, we are not able to hear you. Hello?
Is this better?
I can hear you. How about others? Can they hear?
Yeah, can hear now.
Great,
Okay,
thank you.
perfect.
So moving on to the opioids, we have morphine, fentanyl, alfentanil, and remifentanil. Morphine is not one that we often use as an infusion, whereas the other three we have seen used as infusions. So we'll just go into them. So this is comparing remifentanil, alfentanil, and fentanyl itself. There are different pros and cons to each one of these. So just on the right-hand side, you'll see that alfentanil is not really suitable for those in hepatic impairment, but for renal failure, it's quite a good option. Fentanyl, the same thing. It's not really a good option for those in hepatic failure. With renal failure, it depends. For example, if our patient is on a filter and we are helping the kidney function, then we can use fentanyl, and we will often carry on with it. Remifentanil is not good in either of them either. I don't know. I don't want to go through every single line in this. I've put the information up because we'll be here forever, but I put the information up so I can share the slides with Amaya afterwards and get them sent round. So going on a bit more to the principles of why we use sedatives. So if we have an intolerance of the ET tube, if the patient is fighting the ventilator, they need to be paralyzed, for example, on rocuronium. Patient who's agitated or distressed, to prevent anxiety, a patient with ongoing seizures and surgery. We don't use sedatives to suppress cough. We actually want our patients to cough. Many of them have infections, and if they don't, and we suppress their cough, we could cause VAPS. So how to use sedatives? We want to avoid a peak and trough. So we're ideally looking at the continuous IV infusion, and we often use a combination of drugs. Our protocol, and you'll see the pre-printed prescriptions on our drug chart, the choice of drugs are propofol and fentanyl. We need to do an hourly sedation score, which we'll go over in a second, and titrate the sedative agents to a target. So this target should be set at the AM ward round every day. We should ideally be aiming to do a daily sedation hold, and that allows us to assess the patient, assess how well they're waking up, if they're waking up. And this next point is quite important. So some of our analgesics may provide a sedative effect, for example, the fentanyl, but sedatives do not provide analgesia. And so if we suspect that our patient is agitated because of pain, we need to treat that with an analgesic and not by increasing their sedative dose. So moving on to the sedation scores, we need to do an hourly scoring, as we said, or at least 4 times during the nursing shift. There are several scoring systems available. I've listed them out there. The one in bold is the one that we use, the Richmond Agitation Sedation score, sorry. And if you, at the bedside, when you see the giant bedside observation recording chart, if you turn that over, you'll see on the back many different scores that we use in the ICU. As we said, the sedation goal should be recorded in the notes or in the AM ward round, and also it can be recorded on the side of the chart so that over the nursing shift change, it's there for everyone to see. And ideally for the RAS scale in particular, we are aiming for 0 to -1, unless we need a deeper level of sedation. In one of these cases, for example, traumatic brain injury, a surgical procedure, if the patient is prone on rocuronium. And this is the scale. So the scale goes from -5 to +4, and -4 to 5 is deep sedation, or the patient is unrousable. So this is the level that we would go for if, for example, our patient was prone on rock. and this is what we did during COVID. The ideal sedation score that we titrate to is between 0 to -1, which you can see in the middle. So the patient is wakeable, but is calm, and maybe they can be slightly drowsy, but they are wakeable. And this score is on the back of the observation chart as well. So the problems with sedatives are that they can accumulate over time. Patients can develop either a tolerance or withdrawal to the agent. They can disrupt REM sleep, which can result in delirium. It is problematic for us in assessing pain, especially if the patient is deeply sedated, and also reduced GI motility, for example, if we're using opioids, which can then in turn result in absorption problems. So our ideal sedative would have a short half-life, a quick onset, be inexpensive because we are infusing it over 24 hours continuously. It wouldn't accumulate, it would have minimal side effects and interactions. The patient would be lightly asleep but easily roused, so a light level of sedation, and it would be easy to administer and monitor. So moving on to some sedative agents. Now remember, some of the agents that we mentioned before, so especially the remifentanil, alfentanil, and fentanyl itself can be used as sedatives, but these are specific sedative agents. So propofol is one that we would have all seen. And as per the table at the bottom, so propofol is quite good because it doesn't accumulate and it has a rapid onset. But that also means that when we turn it off, the patient can wake up with a bang. And so that can lead to confusion. The propofol does reduce the patient's MAP. So that's something to be aware of. Many of our patients are on vasopressors, and so it's good to be aware that the propofol is reducing the MAP as well, although we don't often stop it for that reason, because it is a good sedative. Propofol infusion syndrome is characterized by metabolic acidosis, muscle breakdown, renal failure, and bradycardia. And if we suspect that our patient has propofol infusion syndrome or PRIS, we would discontinue the drug. And also to note that propofol, it's got quite a distinct white color. It's formulated in intralipid. And so we need to be aware of hyperlipidemia in our patients, and also patients who are allergic to egg, soy, or peanut, depending on the particular propofol product or formulation. So patients with allergies, we'd need to check the particular container that we have in stock at the time, and we may not be able to use it in those patients. And also due to the lipid, it does contribute to the calorie intake. This is something that dietitians do take into account when doing their assessment. And especially if our patients are on parental nutrition, we would actually reduce the number of calories in the bag if we know somebody's on propofol. So we're going to move on to alpha-2 agonists. So clonidine is our first one. We can't withdraw clonidine suddenly if we use it for a prolonged period of time, so greater than 3 days. This is because it results in rebound hypertension, and it can also cause agitation in patients. Clonidine can cause bradycardia. It can cause hypotension. It's actually used as an antihypertensive agent, and it can also cause fluid retention, dry mouth, and constipation. On the right-hand side, we've written a bit of a warning. So avoid use of beta blockers, tricyclics, NSAIDs, digoxin, and haloperidol. In reality, in the ICU, because we've got continuous monitoring, this would be more of a discussion that we have as opposed to kind of a blanket rule to say, definitely don't give these agents with clonidine. Clonidine also gives a slightly lighter level of sedation than propofol, fentanyl. For this reason, it's quite useful post-extubation. Clonidine can also be given orally as tablets, or tablets can be crushed and put down an NG tube. So for those patients who, for example, an IV infusion is their only reason for not being able to step down to a ward, we do have the option of converting them to clonidine and using tablets, and that'll enable us to step the patient down as long as we have a plan in place on the handover to reduce and wean the dose. Dextor is our other alpha-2 agonist, so the full name is dexmedetomidine. Dextor is the brand name, and it has a similar profile to clonidine. It is very, very expensive, and when Dextor came out, there was a lot of literature published to persuade everybody away from older agents and to use this agent. So just to keep that in mind, if you are reading any papers about sedatives or about sedation, that there might be a strong level of bias in whatever you read. And there is a specific guideline for Dextor in on the intranet. I've just included a couple of screenshots of the useful parts of the guideline, but if you just type the drug name into the search box, you'll come up with this. And it will give you the calculations. It's mainly the nurses use this to do the calculations. There are 2 strengths that it can be prescribed as. So this goes through the calculations, starting the treatment and titrating it. So benzodiazepines, we'll mention midazolam here, and then we'll mention some other benzos a little bit further down in the presentation. So midazolam can be used as a continuous infusion. It's the shortest acting of the benzos, and it works at the GABA receptors. The main thing about midazolam is that it can accumulate, and this is even more enhanced if a patient has renal impairment, renal failure. And for this reason, it's often not the most favorable of sedatives for us to use, because once we turn off the midazolam, it can take some time, sometimes even days, for the patient to wake up properly. There's also a note here to say do not use, so the reversal agent for benzos is flumazenil. However, after prolonged duration on midazolam, we wouldn't use flumazenil to reverse it immediately because this can lead to confusion or convulsions. Midazolam is useful also if we have a patient who we think is seizing, and also often if our patient is withdrawing from alcohol. So these are some other agents which we won't go into in too much detail just now. So ketamine, thiopentone, and some volatile agents. Moving on to delirium, so the third in the triangle of pain, agitation, and delirium. So this diagram is also available on the back of the bedside observation sheet. And this is called the CAM-ICU, so the confusion assessment method. And this is how we deduce if our patient has delirium. So essentially, if they make 2 or more errors and they have a RASS, so the Richmond Agitation Sedation score, greater other than 0, then we would say that they are CAM-ICU positive, which means that delirium is present. Any of the other scores would mean that they are CAM-ICU negative, which means they don't have delirium. This does have its limitations. As you can see, all of the boxes contain questions that we need to ask our patient. And so you'll often see on the bedside chart UTA, meaning unable to assess, if the patient is too deeply sedated. And also, for example, there are limitations if the patient doesn't speak English. So it is subjective. However, if we do suspect our patient does have delirium, the first line would actually be non-pharmacological treatment. So this would be things like the minimizing noise and alarms in the environment, and at nighttime also minimizing light, and restoring the sleep-wake cycle. We would also aim to group together interventions, for example, if you need to put lines in, and medications also, the administration, particularly of IV medications, to minimize disruption to the patient, especially at night. We would encourage family visits and familiar faces, and also reorientation by having a clock at the bedside, reminding the patient of the time, the day, where they are, and if the family can bring in familiar objects as well. The next one's really important. If our patient wears glasses, hearing aids, or dentures, simply putting those in can help and can go a long way to helping to resolve their delirium. And also early mobilization. So this is where physios can get involved. In terms of medicines, there are actually no licensed treatments for delirium in the UK. What you'll often see used in our hospital is antipsychotics, the main one being quetiapine, but you may also see some haloperidol on the PRN side. Depending on the consultant, you may see risperidone or olanzapine prescribed from time to time. The main thing to bear in mind with these antipsychotics is that there is a risk of QTC prolongation. So we do need to monitor the ECG. If the patient is low risk, then alternate days. If they do have a cardiac history or are on other medicines that can prolong the QT, then we would advise a daily ECG. Other medicines that can be used for delirium. So we have other benzodiazepines, clonazepam, lorazepam, diazepam, and clonazepam. The clonazepam we would predominantly advise not to use that for delirium in the ICU, but we would say use it for patients who are acutely withdrawing from alcohol. If a patient has been in and does have a history of alcohol excess, but they have been in for example, a week or two, we wouldn't class that as acute alcohol withdrawal, and so wouldn't advise using clonazepam. And when we do use it, it should have the patient should have a CWA score recorded as well at the bedside, and that will enable us to titrate down the dose as appropriate. The alpha-2 agonists that we mentioned earlier, dexmedetomidine and clonidine, can also be used to treat delirium. So moving on to some questions, we'll need you to unmute for this. So the first question is, which sedative contains 1 calorie per ml? Can anyone hear me?
It's propofol.
Thank you. The second question, which of the following can cause QTC prolongation?
Haloperidol.
Clonidine is particularly recommended for patients with which of these?
Uruj mentioned hypertension.
Yeah, that's correct. Sorry, if you're writing in the chat section, I can't see it. So if you could read it out. So a couple of cases.
There is no mic at the unit, so if someone types it, I'll answer it for them. Is that okay?
Yeah, perfect. Thank you. So
and
the first.
Sorry, I'll interrupt you.
Yeah.
Definitely, I will not answer, but I do expect answers from others, except Zahra, of course.
So the first case that we have, so it's a 65-year-old male who developed multi-organ failure after perforated diverticulum, resulting in fecal peritonitis. He's day 47 on ICU, and he's on PN and also requires filtration. So basically, every type of intervention that we can think of. Today, he's become restless despite us titrating his midazolam up. And he's also got a lipemic serum, and he's hypertensive with a BP of 160/90. Because he's quite restless, it's making it difficult for us to ventilate him, and he's also trying to pull his tube out. So the question here is, what sedative regimen would you recommend for him? And also, what factors do you need to consider when deciding this. So we might want to think about question 2 before question 1. Does anyone want to mention any of the factors they might consider from the information that we have? I guess we can go through it together. So the patient has a lipemic serum, so propofol probably wouldn't be our first choice here. We do need to sedate him a little more deeply than he is at the moment, but we'd also could assess whether the restlessness is delirium, whether he has any pain. The midazolam needs to be stopped because he's probably accumulating at this stage, although he is on a filter. So probably go for an opioid. We could use fentanyl for him because he would be filtering it. Oh, and I forgot to mention as well, because of the PN, if we were to use propofol, we would need to take that into account in the PN, but it's not the best choice here. So probably go for an opioid, which would help to manage any pain that he has, and also give us a slightly more deep level of sedation. And then maybe think about something like, hello?
Yeah, can I ask one question? Can we consider in this scenario, considering his pressures are 160/90?
Did you say clonidine?
Yes.
Yes, we could do. That would also be a good option.
Opioid and clonidine in this scenario would be helpful, isn't it?
Yes. Yeah, so clonidine would be a good option, especially in thinking about whether he's got delirium, and also in terms of weaning him. So we could start off with a fentanyl clonidine combination, and after a day or two, wean off the fentanyl and leave him on clonidine. Okay, so the second case, a 65-year-old lady has just had a fem-fem crossover graft, and due to the long operation, blood loss and hypothermia, she's brought to ICU ventilated and is receiving an infusion of fentanyl propofol. So this is what we would normally give to our patients. She's kept sedated overnight, and in the morning the sedation is weaned, and she begins to wake up, but appears quite agitated, and her pain score is 6 out of 10. What would you do with her medication here? I'm not sure how much time we have, Amaya.
You can how
Okay.
many questions are there?
No, I was just going to go through the answer quickly if we don't have too much time. I think there's just one more after this.
Maybe I think I'll join in the discussion, so it would be interactive as well for others also. And yeah, I would expect everyone to join in this interaction. So in this case, I was thinking about analgesic plan, meaning I would like to increase the dose of fentanyl. What do you say, so?
Yeah, I think I would agree. I'd agree completely with you that her main issue here is not, she doesn't need sedating for the ventilator. The case doesn't mention that she's having problems breathing anymore. So our main issue that we need to tackle here is the analgesia. So there are a variety of things that we can use. We could increase the fentanyl. If we don't want to sedate her any further, we could think about, for example, a PCA that the nurse could help the patient use until the patient is able to press the PCA button herself. And in terms of the agitation, she could also have an element of delirium. So thinking about whether we can use some non-pharmacological methods to orientate her, because the last time she was awake, she was just about to go into an operation, and now she suddenly appeared in an ICU and may not be sure where she is or why she's there.
Okay.
Oh, okay, that's
Something
it.
like I think something this we commonly perform during the ward round, isn't it? That we always try, even the nurses also try to tell the patient what time is it, where are we right now, and we try to introduce ourselves. So if I'm not mistaken, this is a kind of reducing the incidence of delirium as well.
Yes, exactly. So just some of the things that you mentioned are on this slide and others on this slide as well. So that's the end of the presentation. Are there any questions or anything that anyone would like clarified?
Any questions from the audiences? Zara, I have one question for you regarding use of benzodiazepine.
Yeah.
So if a patient uh, is in alcohol withdrawal but is already intubated, ventilated, uh, do we use SIVA protocol?
No.
So
So if our
we will,
patient, yeah, if our
yeah,
patient is,
sorry, please do.
that's okay. If our patient is already intubated and ventilated, then I would presume that the sedation score, if for example we're heading for a RASS of -1, then we would probably see that the patient isn't displaying any of the symptoms that we would see on the CWAS score. Depending on how long the patient is on sedation for. So for example, if that only lasts a day or two, on day 3, when we are extubating the patient, we might want to think about reintroducing a CWAS score there, because there could be a chance for the patient to still be in withdrawal. However, if it's a week or two later that we are extubating, or if patient's on a trachea, then we would kind of be outside of the window for acute alcohol withdrawal. The CWAS score wouldn't be too useful there.
Okay.
We also have the alcohol and drug liaison nurse that can come and assess the patient if we're unsure which window we're in.
Okay. Fine. Thank you, Zara, for your presentation. Thanks to Shovhit also. Sorry, Shovhit, I couldn't join your presentation because I was inducing a patient right now. And Zara, a lot of good points you covered up, and even you clarified my doubt as well. Okay. I will send the feedback form in a day or two. Everyone, please do fill them uh, and do let us know your opinion also. If we can do any kind of modifications, any suggestions that you would like to give. Thank you, everyone, and let's meet next week.
Thank you so much.